working, Justin?
Hi, I'm Skylar Dumas, and this is my Cat 3 video. I have my patient Justin Merriman here with me. He's ready. So first step in the Cat 3 is we're going to go ahead and do the prone leg length analysis. Patient position is prone, docks at the foot of the table. I'm going to grasp the patient's ankles here, put them about 14 inches apart, and ask my patient to press outward for 3 seconds and hold. Go. 1, 2, 3. I'm going to go ahead and check his ankles here, looking at the medial malleolus, looking for the superior one. The superior medial malleolus is going to be our short leg. And we'll use that through the Cat 3 video. Didn't mention Cat 3, it's a disc issue, so we'll just put that in there right now. Second step in this is the glute fiber analysis. Again, the patient's prone. I'm going to state that the glute fibers are related to the lumbar spine, and the PSIS here is where I'm going to push. We're looking for tender points. PSIS is right in that area, is going to be correlate to L5, and then as I go up along the ilium, the next spot is L4, L3, L2, and L1. And so we're going to ask the patient if there's any tender spots on this, and then we're going to go check these again at the end of the blocking and see if they're tender. If they are tender, then we're going to treat them as trigger points. Next thing we're going to do is state the indicators for the Cat 3, which would include glute, calf, or gastroc tenderness, as well as the spinotemporal line, which is right here. And I'm going to go ahead and check all 3 of those on our patient. So after that, we're going to go ahead and go to the SOTO. So, patient's again prone. The indicator for this is sciatica. This maneuver is both diagnostic and therapeutic. So I'm going to go ahead and support the patient's ankle proximal to the knee and ankle here, and I'm going to go ahead and pull the leg out 14 inches or until the glute begins to brunch. At that point, I'm going to laterally rotate the patient's leg, and I'm going to hold here for 10 to 15 seconds and then return to start. I'm going to wait 2 minutes and go ahead and repeat. During that time, I'm going to ask my patient, does it feel better, does it feel worse, or is it about the same? If it's about the same for this patient, so that would indicate a subluxated or a herniated disc. If it was to be worse, that would indicate a sequestered disc.
It's really good.
And if it was better, it'd be a piriformis problem. If it was, in fact, a piriformis problem, then we would repeat every 2 minutes to take care of it. So we're going to go ahead into the blocking for Cat 2. I have a pair of shoes here. Sorry, Cat 3. Did toodaloo later. Again, patient prone. We're going to have the board 4 inches above the iliac crest with the sternal roll in place. We don't have any of those things here. We got a pair of black Nikes. So this is passive blocking. Again, the patient doesn't help. And I'm going to block the short leg, which I believe was my patient's left leg. And I'm going to block the short leg at the trochanter, and it's going to go 45 degrees inferiorly. So I'm going to go ahead and do this here. We're just barely going to put them in there because this is a video for learning, not adjusting. I'm going to go ahead and block the long leg at the ASIS, and again it's at 45 degree inferiority there. The goal of blocking for a Cat 3 is the reduction of plane, and the maximum time we're going to do this is 30 minutes. So next step is the Cat 3 block augmentation. First thing we're going to do is the posterior iliofemoral ligament. Patient's going to be correctly blocked for a Cat 3. I'm going to grasp the patient angles and internally rotate, looking for a restriction from either side. Boom, boom. So here, check those out. So now I'm going to go to the side of restriction, which is the right side in this case, and I'm going to go 1 inch superior and 1 inch posterior to the top of the trochanter, and it's going to be a double thumb toggle towards the opposite obturator foramen. So we're going to get there, right towards it, boom. Block fell out, but that's okay. We'll keep it here. Let's see. So if I replace the block, this would happen to fall out, I would remove it. So we're going to go ahead and do that real quick. And now I'm going to go back to the end of the table, and I'm going to recheck for internal rotation and all as well. So next thing we're going to do is the lumbar inferiority lift. Patients again block for the Cat 3. I'm going to ask my patient to reach up towards the head of the table, and I'm going to flex the patient's knee with my inferior hand And I'm going to palpate the L4, L5 area. And I'm going to, sorry, let me backtrack. So this lumbar inferiority rule, this lift, is for an inferior lumbar, and it could be correlated to a cervical indicator. So oh shoot, let me back up a little bit. I was on the lumbar vertebral derotation, got confused. So I'm going to flex the patient's knee, and I'm going to put the push on the spinous process on the side of rotation, so it's going to go lateral to medial. So if I had the spinous process rotated this side, I'm going to go ahead and flex the knee, push that way. So the lumbar inferiority lift, my line of drive on that is lateral to medial. Back to what I got ahead of myself into, the lumbar inferiority lift. Properly blocked for a Cat 3. I'm going to have my patient traction the head of the table. I'm going to flex the patient's knee, and I'm going to push on the TVP on the side of inferiority, and my line of drive is going to be I to S. Again, this lumbar inferiority may be linked to the cervical indicators. Next thing we're going to do, acetabular goading. So once again, patient's block, flex the knee, and I'm going to palpate the acetabular area for any nodules that may be there. And so I'm going to grab the flex knee here on the ankle, palpate, and I'm going to go ahead and make little circles here on any of these nodules that I find, and I'm going to work those out. I can internal or external rotate, work them all. Next thing we're going to do here is orthopedic blocking, so that's in here. Patient's blocked, and I'm doing this to derotate a vertebra, and I'm going to go ahead and say that there is a spinous, or I'm going to pull the block on the side of spinous rotation. And that's also going to be on the short leg side. Okay, next thing we're going to do is sciatic traction. Patient's going to be blocked again. We'll keep this here just for fun. Indicator for this is sciatica. I'm going to have my patient once again reach up and traction to the head of the table. I'm going to traction the sciatic leg. In this case, it's his right. And I'm going to do that off the ankle, just a little more proximal. And I'm going to hold that bad boy for about 5 to maybe 10 seconds. And I'm going to repeat this until the pain is gone or until we no longer see improvement. Alright, so now I'm going to go ahead and show you the analysis and correction of the sacral base. At this time, the patient would be prone, blocked, just like you're doing a Cat 1. I'm going to go ahead and put my thumb on the L5 spinous, and I'm going to have my patient cough like a man. And at that point, I'm going to watch which way my thumb goes. If it goes towards the ceiling, that'd be a sacral base positive. Towards the patient's head, sacral base negative. If it goes somewhere in between there, then that's going to be a sacral base neutral. So if we have a sacral base positive, I'd rearrange my blocks so they're facing like a smiley right here. And they're going to be placed at the level of the ASIS. My segmental contact point is going to be the sacral apex. And so I'm going to go ahead and get that. And I have my patient take a deep breath in. And I'm going to push. And on exhalation, I'm going to relax. So on inhalation, I push. And we're going to do this 3 or 4 times. So now that we did that, we're going to go ahead and show you what the sacral base negative is all about. Like you'd imagine, it's about opposite to the sacral base positive. And we're going to move the blocks to a frowny face. And that's what's opposite. So we do that, we're going to go ahead and contact the sacral base at this time as opposed to the apex. And I'm going to push during exhalation. So okay, patient, go ahead and breathe in. And breathe out. And breathe in. And I'm going to be perpendicular. Okay, so next thing we're going to do a sacral base neutral. My blocks at this time are going to be perpendicular to each other. Shoes aren't standing, so we're going to leave the shoes on the floor. But you get the idea. So here we're going to block between the ASIS and the trochanter right in the middle there. And I'm going to go ahead and be on the sacral apex during inhalation, sacral base during exhalation. So I'll get there and go ahead and breathe in and out. And in and out. And in and out. So now that we've completed that, we're going to go ahead and go to the post-blocking techniques, no blocks needed. Next step is the sitting disc. So I'm going to have my patient go ahead and face this way, sit in the seating position. I'm going to contact the inferior tip of the involved spinous process. So we're going to say L4 at this time. I'm going to ask my patient to flex his cervical neck and remain flexed the entire time. So I'm going to go ahead and push I to S as my patient bends forward and inhales, keeping his chin tucked on his chest. I'm going to push P to A as the patient sits up and exhales, keeping his chin on his chest. I'm going to go ahead and then push I to S as the patient bends forward and inhales and keeping his chin on the chest. And I'm going to repeat that 3 times to help reduce the pain. This is a great technique if all else has failed and your patient is trying to avoid surgery. So go ahead and take a deep breath in. I'm pushing I to S. I'm pushing P to A. Deep breath in. I to S. P to A. Next thing we're going to do here is the side posture for the post-blocking technique. Indicator for this is sciatica. We're going to put the sciatic leg down so it'll be his left leg, and this time have him lay down here. And I want my inferior TVP, I want that bad boy to be up. I'm going to go ahead and contact a mammillary with my fingers pointing up the spine. My line of drive is P to A for rotation and I to S for that little bit of inferiority we're messing with. I'm going to go ahead and get behind my patient here. And boom. That's it, folks. I appreciate you watching my video and taking the time.